So in this part of microscopy, we're going to be going just into the fluids. We're going to be going through each one individually, what you need to know about how to process them, how they're made, their function, and what we're looking for when we look at these specimens. For the CSF, as you know, or as you should know, it comes from, it is the fluid that surrounds the brain and the spinal cord. And so obviously it is supposed to be sterile. And it is produced by the, the three different meningeal membranes that exist in the central nervous system. These membranes include the dura mater, which is the outermost layer, the arachnoid mater, and the pia mater, which is the innermost. So that's the order from outer to inner. And the CSF is present in those spaces in between those membranes. Its major function in those spaces is to circulate through that space, bathe the tissues that are there, and provide some mechanical structure to it so that they prevent the brain and the spinal cord from sort of knocking around in their compartment. Remember, in the brain in particular is at high risk because it's surrounded almost completely by bone, which makes the pressure and the risk of this tender tissue knocking up into a very hard structure dangerous. The presence of the liquid functions to keep the brain still so that every time you turn your head it doesn't knock up against one side of the skull or another. Every time you get in and out of your chair, that things don't slosh around. Okay, so the CSF is supposed to circulate through that space, and the main space is between the arachnoid and the pia maters. And it'll be produced by the choroid plexus within the third and the fourth brain ventricles. And the way it's produced is the plasma is ultrafiltrated, so it's this is not exactly the same consistency as the plasma is, so it's not like you just remove the cells and you have CSF. There's actually other materials that are secreted in by the cells within the choroid plexus, creating a new and different kind of fluid. The fluid volume will vary. A lot of the variation will come based on the size of the person, and you can see that in the total normal volumes from an adult to an infant. So the adult you can see between 90 and 155, the child between 60 and 100, and the infant between 10 and 60. These volumes are generally replaced as the fluid is absorbed and secreted or filtered by the cells approximately every 5 to 6 hours. Okay, and that's in an adult. That can happen at different rates depending on any kind of issue that's going, any kind of illness that's going on. Okay. Major function, anybody who's ever been hit in the head knows that the major function is to cushion the CNS. You get hit in the head, you don't want your brain to smash up against the opposite side of your skull. It also, though, does help to prevent against changes in pressure. When you have this nice tender tissue encased in bone, any inflammation, any changes in pressure can be significantly damaging to that tissue. So changes in that volume of CSF can help to account for those changes in pressure. Okay, but it also has kind of an immediate function to collect waste and circulate nutrients. So it helps in that way, it helps to maintain the homeostasis of the environment of the central nervous system. And then finally, it will also act as part of the buffering system of the brain, in particular as a buffer, in the sense, not a buffer necessarily as we think of it as a chemical buffer, but also we think of it as part of a buffer, kind of like a train buffer, a prevention mechanism. The The CSF and the choroid plexus, which creates it, will regulate what's allowed into the central nervous system and what isn't allowed into the central nervous system. So the choroid plexus is the major site where we consider the blood, which we consider the blood-brain barrier. Okay, if it's going to get into the CSF, it's going to have to be able to get past the choroid plexus. Okay, so that area where the CSF is created would be considered the major stumbling block for most, for many things. I won't say most. So, like for example, glucose. Glucose will diffuse very easily through the choroid plexus, no problem getting through. However, glucose is a moderate, it's not a very large molecule. Some proteins, very large, most proteins, much more large, and so those would be restricted from access to the CNS. Many of the medications that we get from a micro point of view, antibiotics, from a treatment point of view as far as chemotherapy and things like that, being able to get medications past the choroid plexus or through the blood-brain barrier is a significant stumbling block. So there's a large number of medications, proteins, things like that. They won't enter into the CSF. So we expect then there to be a difference if we look at the, say, glucose levels of the blood and the glucose levels of the CSF. They're not exactly the same, but they will be reflective. If you have a high plasma level, you'll have a high CSF level, and vice versa. If, when we're talking about other things, however, like the, pardon me, like proteins, most proteins are restricted from the CSF, so there's it's not reflective of the plasma levels. Albumin, many IgGs, those are not diffuse into the CSF. Okay, so those things we do have to take into account when we look at their relative concentrations between the two. Now the normal levels, this is normals when it comes to any fluid situation are difficult to really characterize. And the obvious reason for that, which stands out right away, is the fact that if you're normal, if you're not ill, we're not going to just go and take CSF from you, right? That's not the way medicine works. We don't experiment on people just for the sake of experimenting. So figuring out average solute concentrations in CSF and plasma. Plasma is pretty easy. We can go around and take blood from people, no problem. People even, they don't mind doing it for science. CSF is a totally different thing. It would be really disreputable of us to go around doing lumbar punctures on patients who are perfectly healthy just to see, let's see what your sodium level is. Okay, so the value of the normals, and they're given here in this chart, the value of the normals, these are not necessarily as accurately represented as in the plasma levels. So the plasma levels, especially across ages, so the plasma levels, we know what is normal at the various ages and health situations for men, for women, the whole thing. CSF, we're a little bit looser on how, is the sodium really almost equal to the plasma level. Potassium, you can see, is about half. Magnesium is more than, so a little bit more than. Calcium half. If you go down this list, is this information necessarily 100% reliable? That becomes an issue. And then the same thing here with some of these levels as well. We don't do these levels routinely. We do glucose levels, we do albumin levels, but all the other levels, and we do, of course, cell count levels, but we don't do this on normal people, healthy people. We do it on people who are sick. So these might represent some skewed data. But these are here for you to look at. The key ones that you should definitely know that I want you to take note of are the total protein, and glucose. Those are vital for you to note. And then if you go over here, it's just given as albumin over here, but the cell counts, obviously, perfectly normal. Very important for you to do. And there's your glucose again. Now, the specimen itself, the reason that we would collect this specimen, you need to understand when we would collect this specimen. Um, Again, a person's perfectly healthy. They come into the emergency room with a cold, but otherwise healthy. We don't collect CSF from anybody who walks in the door. So there have to be specific clinical indications, and that's because the procedure itself, of course, is somewhat risky for the patient. Every procedure contains some risk. The risk of the CNS is a little bit more than others, more significant than others, so we don't do it willy-nilly. So the clinical indications for collecting a CSF specimen would obviously a suspected infection would be important. If we suspect a subarachnoid hemorrhage and can't diagnose it using radiology, there's a possibility we might collect a specimen also to relieve pressure. That has been done for a hemorrhage. If we suspect malignancy and various demyelinating diseases, so central nervous system disease. So if you're suspecting a disease specific to the central nervous system, an infection specific to the central nervous system, or in the case of a hemorrhage, you might also suspect those. These would be legitimate reasons to collect a CSF. But we don't collect CSF just because a patient gets, migraines. That's not a reason to collect a CSF, even if it's, central nervous symptoms. The specimen is collected most commonly via lumbar puncture. However, there are other ways to collect it, and the second most common way would be via a shunt. So there are patients who contain shunts from their brain, mostly their brain. And the shunt that is most commonly in place from the brain is called a Jackson-Pratt shunt. So if you were to receive a fluid from a Jackson-Pratt, and they can potentially label the fluid that way. But if you received a fluid from a Jackson-Pratt, you would know that that's actually a CSF, whether it's labeled that way or not. And so you need to treat that specimen as a CSF, okay? If it says brain shunt or something like that, obviously we know that would be a CSF as well. So there are patients, mostly they have buildup of fluid on the brain, and so the shunt needs to be put in. Just in case you don't know, a shunt is an artificial tube that's put in to drain excess fluid from one area of the body to the other, and these shunts are placed in persons' necks to remove increased fluid from the brain. And increased fluid in the brain is, by definition, CSF. So we treat those specimens as sterile. We treat them as any other CSF that comes in to our lab. Okay. These specimens should come down, and they generally do, in special plastic tubes. The tube is a conical tube, and it has a special base to allow it to stand up on its own. The purpose of which is really for the clinician as he collects the specimen. There are kits that the doctor opens. They're sterile kits that contain 4 of these non-glass containers, which are actually labeled with numbers on the side of them, and they must be non-glass. Okay, we don't use glass in the modern clinical laboratory anymore anyway, but CSF can interact with the glass, and you can get what looks like, or it actually will look like clotting, so you definitely don't want that to happen. You remember this hopefully from methods. The tubes that are labeled 1, 2, 3, and 4, as long as the doctor actually follows the numbering rules, he or she should understand that the first tube will go to chemistry for chemistry testing, the second to micro, third to cell count and differential, and fourth for any specialized tubes. The reality is that in most cases we only get 1 tube. Okay. So in that case, if you only get one tube, the first lab to get the tube has to be microbiology because we need it to be sterile. Okay, that's the first that's the first lab that should get it. The most important lab to get it is hematology because we have to have that cell count. That's the most important information that we're going to get out of there. Okay, so a little bit different there. Generally we get one tube. From the majority of our patients, we get one tube. If you have enough for all of the labs, then the first lab that will get it will be microbiology. If you don't have that much in there, you need to make sure hematology gets theirs because that's the most important information. Okay. So this is where you really need to be in contact with the physician who collected it. I have heard from more than one physician them say, you know, what do other doctors order on these things? They know that this is an important specimen. They know that they can get important information. This is especially your younger doctors and your residents. They know it's important, but they don't necessarily know everything that they want. You know, they're kind of like, they want everything, but they can't get it when they only collect 1 cc. Okay, so in that case, with 1 cc, you can do a culture and a count easily and probably get the chemistry in as well. But you definitely want the count, okay, the cell count. The things that they will note for the lab tests on CSF, the first thing that they're going to note is you actually won't have any part of it, but the doctor will note opening pressure for a CSF, which basically, remember, it is everything's encased in bone, so there's a certain amount of pressure there, and the physician will have to note the opening pressure. Is it very high? Is it very low? That kind of gives you a relative amount of what might be going on as far as circulation and production of that CSF in that patient. Definitely have to have a cell count. Total cell count plus diff. We don't do one or the other, we do both. If you have cells, then you differentiate them. Okay, so we do that on each one. The other thing that we definitely look at is glucose levels. Glucose is important for us. It's an important indicator of infection. And so we need a glucose level with a concurrent plasma level so that we can compare the two and decide, is this likely a bacterial infection, if an infectious disease situation is what we're talking about, or is it a viral infection? Okay. And then protein levels are also a good marker of increased cell counts, increased inflammation, things like that. The protein will increase. It also signifies decreased increased permeability at the blood-brain barrier if you have increased protein. When indicated, you might need to order cultures and stains on that. So cultures in micro, various stains in cytology. Special serologies, those would be specialized testing, which even PCR, cytology, all these different things are based on what diseases the physician suspects. Okay. Now, when you get the specimen in the laboratory, the first thing that we do, just like in your analysis, we will do a macroscopic report. So we'll look at the specimen, and a CSF should be, a normal CSF should be completely clear, and it should be completely colorless, and it should have no clots. Okay, so if you look over here at this specimen, you can see that the specimen on the right is completely clear and it's completely colorless, as opposed to the specimen on the left, which is, it is clear, but it has color to it. That's not normal for a CSF. This has I would call this a yellow tint to it, but what we report this as, if you spin this and the yellow color remains, we call this xanthochromia. Okay, so you would either say that the specimen is xanthochromic or it's not xanthochromic, or it's clear and colorless. Okay, this is a sign of the presence of either blood or hemolyzed blood or old blood. So you might find xanthochromia in particular in cases of hemorrhage. Okay, so for patients who have had a hemorrhage in the past day or so, frequently we see xanthochromia in the specimen. It also can be found, color, I should say, can be found with various other situations, and these this little chart gives you the reasons for that. Obviously, any pink to red color could be due to one of two things. Either there is active bleeding in the CNS, or it was a bloody tap. So a bloody tap means that the procedure, the lumbar puncture, unfortunately hit capillaries and you got blood as well as CSF. So here we say call that a traumatic tap. So usually you can tell the difference in that with traumatic tap, after you spin the specimen, all the blood cells will be at the bottom in a button. And with a traumatic tap, you don't usually have xanthochromia, okay? Because those are fresh red cells. They're not lysed and, they're fresh. With hemorrhage, however, especially hemorrhage that's been going on for more than, for some time, the cells, as they enter the CSF, they lyse, they break down, and that's where you start to get the yellow to orange to pink color transformation of the CSF. If you have something that's yellow to yellow-green, that might be actually a result of bilirubin present in the CSF. That would be, obviously the patient has significant liver disease in this case, if you have it backing up into the CSF. The yellow can also, where with jaundice and bilirubin, it would have more of like a yellow-greenish tinge towards it. Yellow on its own, frequently associated with higher protein levels as well. And rarely and most likely with infants, we do get orange tint to the CSF, and that's because little kids are orange all the time because they eat nothing but carrots and orange stuff. Okay, so they end up, everything appears orange. Brown color would not be normal, and that would be a good sign that the patient does have some kind of melanoma going on somewhere. Obviously, if you've got melanin being secreted into the CSF, it's a pretty good sign that it has metastasized to the meninges. And then finally, this weird red-orange color has been seen with rifampin therapy. So the patient's on IV rifampin, and we sometimes see this red-orange color. Okay. The key thing here would be to differentiate it from any red or orange color that might be associated with bleeding. So you'd have to be able to differentiate that. Obviously, rifampin therapy you'd not be able to spin it out, okay, and create a button. With blood, you would be able to create a button. Again, this is just another chart for you to look at the gross appearance as far as the cloudiness. You can see normal CSF should be completely crystal clear. It should not have any cloudiness to it at all. Once you see some kind of turbidity or cloudiness, then you're starting to look for what's causing it. Cells certainly are going to cause it, and that's our most common result that we find. Obviously, microorganisms can, but also increased protein that we do see with certain diseases of the brain. Okay, we will see increased protein. And then you can see the rest of these things. So the ones that I want to point out that are a little bit different, we went through the color changes already, but X-ray material, patients are supposed to have specimens collected before they receive contrast material for any radiology studies that they're doing. The specimen has to be collected first. That X-ray material is going to interfere with our results. Okay, so what that does is the X-ray material actually appears almost like little oil droplets within the specimen, and so they're a different consistency, and so you end up with something that's going to interfere with your results. Okay. For viscous specimens, they do occur in particular with particular infections, Cryptococcus neoformans, which produces, in some cases, a very thick capsule, can give you sort of a thickening of the CSF, as well as certain carcinomas that produce mucin. And then finally, there is always the possibility in a really, really bad traumatic tap, it is possible that the material that's inside your discs in your spinal column this would be a really bad traumatic tap, but the doctor could have punctured the disc, and then that material, you end up with that material in your specimen instead of just CSF. How do you differentiate that? You're just basically you're ruling out the other, there's no infection, patient doesn't have a carcinoma, likely we got some kind of disc in there. Okay, and then clots. We don't normally see clots from in a CSF. There would have to be a significant amount of plasma in the specimen with the coagulation factors there to form that clot. And so that would happen most commonly in a traumatic tap, but it can also happen with a hemorrhage. Okay, so the patient has a stroke where then potentially even an aneurysm, and you end up with blood in the CSF, which would include your coagulation factors. So you have to do that macroscopic exam, but then what's our next job? We're in microscopy, so we have to do a microscopic exam. Okay, so remember what I said, the most important test when they collect a CSF really is the count, the cell count. Okay, so making sure that we get that microscopic exam done right away is important, and that's because cell deterioration in a CSF will start within just a couple of hours of collection. So as a general rule, the clinical staff has a sense of urgency when it comes to these specimens, but pardon me, we have to make sure that that's across the board and that we get these specimens as soon as they're collected. Okay, literally they've done studies within 2 hours. If you have more than 2 hours that you've held that specimen, not done your microscopic on it, you can see up to 40% of the white cell lyse after 2 hours. So again, getting it to the lab and getting the procedure done right away is important. Now, the traditional method for doing a microscopic exam for a cell count would include the hemocytometer, which I know you just enjoyed using so much in hematology. When I was coming up, that's what we used because automated systems, they weren't all that great working with CSFs, okay? So they've improved the automated systems to the point where we actually do use instrumentation to get cell counts on most of our CSFs. However, if you have a really low cell count, like for example in a normal CSF, you might have to verify that with a hemocytometer. It depends on the procedures at your lab. In particular for the diff, when you're only talking a small amount of white cells, if you look here for pleocytosis or increased white counts, mild pleocytosis is 5 to 50 white cells per microliter. These are not high numbers. 15 to 200 for moderate, marked as greater than 200 white cells. Okay, so when you're talking about the patient, we saw 10 cells. Oh, that's a little bit high, right? But now you take your sampling error comes into play. Try and do a diff off of 10 cells. That's hard to do. So having that hemocytometer and being able to get the full count is important. Okay. When you do the count, when you do the total count, normal for adults, meaning so there are a few white cells within the CSF normally. It's not like they're completely absent from the CSF. 0 to 5 per microliter, that's about right. Neonates, look, you'll see here, it's slightly higher. And part of that is the fact that they have slightly less well-developed blood-brain barrier, and also the fact that, pardon me, they're building their own immune system, so they've got a lot of work to do there. If you look at the diff that's normal, you can see that between half and most should be lymphocytes, followed by monos. Neutrophils, you can see, and the rest of your granulocytes, they drop down. They're the smallest amount. Okay, neonates is a little bit different. Your monos are your largest percentage, with the lymphs and the granulocytes being much less common. Okay, so that's important. So these are the normal numbers. So when we see increases in the total white cell count, we need to look then at the differential that we get and see if is it increased total count but still normal ratios, or is it increased and abnormal ratios. Those are the kind of things that you're going to have to examine as you look at these. Now, one of the issues when we're doing a cell count on a CSF is the issue of the traumatic tap. Traumatic taps are easy to happen. It's just a reality. Not everybody's spine is the same. It's not easy to get that needle in the right place to collect a completely without hitting a capillary. So if you suspect a traumatic tap, you'll need to correct for the blood that was introduced into the specimen. We don't really want to include that blood in our cell count. Okay, now this is giving you just the white cell count. Red cell counts, having a few red cell counts is fine, but when we see a whole bunch of red cells, we need to be able to differentiate from traumatic tap and hemorrhage. Okay. The first thing that you're going to do is make sure that whatever tube you have is yours until you're done with it. You do your cell count. Remember, we're supposed to do it on tube number 3. You can't then say, well, I started it on tube number 3, but I ran out. Let me go get tube number 1. It has to really be done all in the same tube in order to be accurate. Okay, and there's going to have to be, if you suspect that it's a traumatic tap, you're going to have to make some corrections to the numbers that you get in order to account for those red blood cells that were added. And that correction formula is here. You're going to give a corrected white cell count where your WBCs are added are accounted for by this formula here. You're going to have the white count on the blood times the red count on CSF divided by the red count in the blood. Okay, this is going to, then you'll get the WBCs added from that formula and subtracted from your total WBCs observed in the CSF. Okay, and this correction formula works very well. Okay, basically, what we see here is that for every 700 red cells that are added to the I'm sorry. Basically, what we see is an increase of about 1 white cell for every 700 red cells that are added to the specimen. Okay, so if we know what the red cell count is in the patient's own blood, we can account for what was added and generally correct for that white cell count. The same thing has to be done for protein because, of course, there's a lot more protein in your plasma at the capillary level than there is in your CSF. So in that case, for every 10,000 red cells, about 1 milligram per deciliter of protein is added. And so to correct for possibly added protein, you use this formula here, where you have the total protein of the serum times the hematocrit, and you take that number and multiply it by the CSF red count divided by your blood red count, and that'll give you the total protein that was added to the CSF sample. And you can subtract that from the total protein tested in your chemistry analyzer. So those are things that you would do once you suspected that you had a traumatic tap. What's the evidence that there is a traumatic tap? Well, the evidence, the biggest evidence is that tube number 1 is quite bloody and tube number 4 is not as bloody at all. Okay, that's very good evidence of a traumatic tap. Okay. As opposed to when you have a hemorrhage, when there's an actual hemorrhage, the blood amount will stay the same through all of the tubes. Impossible to assess this if you only get one tube. Okay, so there's nothing you can do about that. You kind of just have to rely on the physician letting you know if he or she thinks it's a if it's a bad tap. Okay. The other thing, one of the things that we see, and this is a picture of it up here, these are macrophages that were seen in the CSF, and they're filled with hemosiderin, which are these little brownish, greenish crystals in the macrophages. Those are hemosiderin crystals, which makes these siderophages. Okay, these crystals, these golden, brown, yellow crystals, are much more indicative of a subarachnoid bleed or some kind of hemorrhage. In a traumatic tap, you're not going to see these crystals. So these crystals take time to develop. Okay. You may, however, potentially see white cells that actually have red blood cells in them. That's possible for a tap. It's not exclusively a tap, but if you see siderophages, it's definitely not from a tap. Those siderophages are from a hemorrhage of some sort. Okay, the cells that you're going to see that you have to be able to identify in a CSF, pretty much the same cells you have to identify everywhere else, okay? But their presence is associated with, their increased presence is associated with certain clinical signs and symptoms. And this chart is just letting you know what those are. Okay, so you can see here lymphocytes, you're kind of the type of infections you see those increased in, neutrophils, where would you see those increased, and so on down the line, okay? And then note your interesting cells here, your erythrophage and your siderophage. Those are associated with hemorrhages, lipophage, same associated with necrosis, some kind of trauma to the brain, tissue death. Plasma cells, malignant lymphoids, and you can see. You guys can read this, so it's nothing particularly earth-shattering here. So what do they look like? Okay, so again, we don't take CSF from normal people that are sick, but what you can take CSF from a person who's sick, and it ends up being normal, and that's kind of where we get our normal ranges. So even though they have neurological symptoms, they don't actually have any disease state going on in the nervous system, which we determine from the cell count, chemistries, and other test results. However, when we do see things in the CSF, we have to be able to identify them. Okay, so in this up left, you can see these are mixed cells. So you see the different arrow. You have the arrow head, the long arrow, there's your seg, there's your lymph is the short arrow, and your arrowhead, that's your mono. Okay, they look the same in CSF as they do in blood. You'll note though, no red cells. Right? No red cells. So in this particular case, we have lots of white cells going on. These would obviously be some kind of inflammatory situation. And in this particular case, it happens to be a granulomatous meningoencephalitis. So this patient has inflammation of the meninges and brain tissue. Okay. In this case over here in the top right, you can see the segs here. You have a mono right here on the far right, but the rest are segs with their segmented nucleus. These are just Gimsa stains, so it's not difficult to read. But I want you to look at this cell in the center. You can see these three little circles, and they're obviously in a vacuole inside the cell. You can see the covering of the vacuole around those circles. This is a case from Cryptococcus meningitis. So the patient has a yeast growing in their central nervous system. Cryptococcus happens to be able to do that very well. There's another vacuolated yeast cell up here where the white cell is trying to destroy these. Okay, so in this case we know that the patient has a yeast infection, and we know it's an infection because the white cells are attacking it, and we can see the yeast cells inside the white cells. In this case here, however, the patient obviously has increased white count. This is not less than 5 cells per microliter. This is a lot of cells. And you can see that if you look at them closely, it's a little bit small. But there are more lymphocytes in this particular case than there are segs. That would be a sign of viral meningitis, which you see that the preference for lymphocytic increase, okay? Whereas with bacterial or in this case fungal infections, you see the segs attacking. And then bottom right here, this is also from a CSF. These are lymphoid cells, okay? They're large lymphoid cells. These actually were observed in a couple of cases of a mantle cell lymphoma. And so these are abnormal lymphoid cells. And you can kind of tell by the way their nucleus looks. You can see that the chromatin, it's kind of all over the place. They look like monos, but then again they don't. They have enormous nucleoli. They have exaggerated, normally in monocyte we like to just see a dent. These are exaggerated. This is beyond dent, right? And we have the chromatin doesn't have kind of a tight feel to it, an even feel. It's kind of more lacy, and which they call dispersed. Okay. You're going to remember you have lots of patients who have these cancers, and they're going to be presented in the CSF. The cells don't look different in the CSF, just the numbers of those cells will be different. Okay. Now you're going to do chemical analysis of your CSF as well if you have enough. That it does give you good information. I would say it's probably a better marker than, or an easier marker to do than a culture, because we can look at the glucose, we can look at the protein and get a pretty good picture of what's going on. You definitely want to do the glucose level for a CSF. Glucose does cross the blood-brain barrier pretty easily, and it's also transported back across the blood-brain barrier. And for that reason, the level of glucose in the CSF is not the same as the level of glucose in the plasma. It should be approximately 60% or 2/3 of the plasma level, which you can see here. It just gives you normal range between 50 and 80 milligrams per deciliter. This requires that we know what your glucose level is, because if you have a diabetic, then you need to understand that maybe their normal plasma level is higher, so their normal range for the CSF should also be higher. For this reason, you should have a concurrent blood specimen in order to test that plasma glucose level. Also in infants, we have slightly higher to CSF to blood ratio, a little bit more close to 80% of the blood level, which is basically a representation of the increased permeability of the blood-brain barrier. That glucose level will be decreased in the following conditions. So you can see in meningitis, in bacterial meningitis, mycobacterial fungal meningitis, those situations, the bacterium are actually using the glucose, and so it decreases the glucose level in the CSF. Viral, it will not be decreased at all. In certain inflammatory conditions, you're going to see a decrease in the glucose level, okay, which is not uncommon in general as well to see that the glucose level might be decreased because the inflammation actually will affect the permeability across the choroid plexus. Hemorrhage, you might see a decrease in the glucose pardon me, in the glucose level. And if you have cells in the area, they'll actually use the glucose as well. So using up the glucose is definitely something that might go on. And of course, the case of hypoglycemia, which is kind of a false decrease. If the patient has low glucose levels, this is why you need to really do the glucose at the plasma level at the same time. If the patient has low glucose, then don't look for it to rise to the level of 50. You know, if their glucose is much lower, if their normal glucose is somewhere around, 80 or 70, then you have to adjust your normal range for that patient's CSF. Okay, and so in order to assure that you do get a good reading, do it with serum levels. Okay, make sure you take a serum level at about the same time. It takes approximately 4 hours for glucose to reach equilibrium across the blood-brain barrier. So what does that mean? So a patient who takes in a glucose dose right now, we will see a pretty rapid increase of glucose in their plasma. It really won't take that long, a few minutes. Okay. Remember, if you've ever had a glucose tolerance test before, we can see changes. We wait 30 minutes for us. You take your dose, 30 minutes later, we do your first glucose level. That's pretty rapid increase in the plasma compared to what you took in your stomach, right? However, it would take about 4 hours for that to be seen, that increase to be seen across the CSF. So it is a little bit slower. There's a little lag time behind the plasma. So that's important to note. If you get a patient who's in an emergency situation, it's not a timed test. You need to know when the last time they ate was, because you might see changes in the relative ratio. The other test that you definitely are going to want to do is a total protein. Okay, total protein normally, the protein that's present in the CSF will normally come as the plasma is filtrated at the choroid plexus. Only a tiny amount of protein will be, a relatively small amount, will be allowed into the CSF. The central nervous system itself only makes the tiniest amount to contribute to the CSF concentrations. Okay, so for the most part, if a protein makes it into the CNS, that will depend on the size of the protein, the molecular radius of the protein. It'll depend on the charge of the protein. It'll depend on the plasma concentration of the protein, because it'll only move down a concentration. And then the fourth thing, which is what we're really looking at, is what is the functional state of that blood-brain barrier. Okay, increased permeability, higher protein levels. Decreased permeability, normal. It's not really decreased permeability, it's normal. Okay, but if you have higher protein levels, we are looking at as a problem with the permeability at the blood-brain barrier. Okay. And the proteins that we're mostly looking for would be prealbumin, albumin, and transferrin. Those are the predominant proteins that we are looking for in the CSF. Okay. As there's more and more damage to those tissues at the blood, in the choroid plexus, we're going to see higher and higher levels of protein. Okay. Now, this is not a sensitive test. Okay, I'm sorry, it's not a specific test, but it is a sensitive test, because even small amounts of damage will show an increase in protein levels. Okay. Now, the methods that we use to detect protein, they're not going to be the same as the methods that we use to detect protein in a serum. Okay, and that has to do with the relative concentrations. Most of the methods that we use to detect total protein in a serum, they're not sensitive enough. They can't detect these tiny amounts. So instead, we use a couple of other methods. Certainly, the Biuret method would work fine. That's obviously, you all did that in inorganic chem. It works pretty well. We can use a benzethonium chloride method, or a pyrogallol red method. And we've also been known they can use the modified reverse Biuret method. These methods are used because they're more sensitive to lower levels of protein. Okay, but no one of them will be able to detect every single CSF protein. Okay, so a lab has to choose the one that um, they think will most represent the situation that they have. And in a hospital like Sloan, you might have more than one method available depending on what's going on with the patient. Okay, are we talking about very low molecular weight proteins that we have to try to detect? Are we talking about just large volumes of proteins? It really depends on what you're looking for, and which method you should use. The only thing you need to know is that we don't use the same methods for CSF protein detection as we do for serum protein protection. So you can't just run it on the instrument in the same way you would run a plasma. Okay. Then we look at, again, it is always best to do a CSF level when you have a serum level to compare it to. And so we have the CSF serum albumin index, which is just a ratio, okay, where we compare the milligrams per deciliter of albumin in the CSF to the grams per deciliter. It's considerably different amounts, grams per deciliter of albumin in the serum. Okay, so it's an established ratio that allows us to use these numbers to associate with an amount of damage that we associate with the blood-brain barrier. So if we look at this index, if you get a CSF serum albumin index of less than 9, it is most likely that your blood-brain barrier is intact. You're perfectly fine. Okay, and as it rises from there, you get increasing impairment to that barrier. So between 9 and 14 is associated with mild impairment. Between 15 and 30, moderate impairment, and greater than 30 is associated with severe impairment to the blood-brain barrier. Okay. Now to continue with the chemical analysis, when we get into the rest of these analyses, each of these analytes will be specific to a particular diagnosis that a doctor is trying to either rule in or rule out, okay? Whereas the glucose and the protein, those should be ordered on every CSF. They really should be. It gives you very good information. Great indicator. The glucose, you need to differentiate between the types of meningitis that you might have, and the protein gives you an overall look at the permeability there at the blood-brain barrier, which is really the key, okay? These other ones ordered at much less common rates, okay? They're much less commonly ordered, but you need to know what they are in case, in case they're ordered. Okay, so lactate, which I'm sure you know, is produced when lactic acid loses a protein from that carboxyl group during anaerobic metabolism. Okay, it's just a normal byproduct of anaerobic metabolism. This is not the same lactate it's not created in the same way that we would normally test for serum lactate levels. This is actually constantly produced, lactate is constantly produced from pyruvate during anaerobic conditions. Pardon me. And we do see these levels in the CSF at a certain rate, but and the normal level for lactate in the CSF is between 1 and 2 millimoles per liter. Okay. The lactate level, it's not like we look at this. Yes, it is associated with anaerobic activity, but we generally don't associate it in the CSF with, like, you had a really great workout. if we do your lactate levels following a workout that we would normally go, a triathlon, something like that, we would normally expect to see them increased in your serum, okay, because your muscles had to undergo anaerobic activity. In the CSF, however, what we're looking for are signs of hypoxia, so blood loss to some part of the brain. Blood loss meaning oxygen loss to a part of the brain. Oxygen loss meaning that the tissues there have to undergo anaerobic respiration, which, if you go to your diagnoses, what would that be associated with? Stroke. Okay, so what we're really looking at there is stroke, potentially other things like tumors and things that can end up with the same results. Okay, so the levels are not, again, they're not related to serum lactate levels. So you can't, it's not like you can take a serum lactate level and compare it to your CSF lactate level. It's not the same. We would see increases in CSF lactate in the case of hypoxia of the brain, which is never normal. Hypoxia of the muscles happens when your muscles are overworked. It doesn't happen in the brain. Okay, so a little bit different. It is used to help differentiate between bacterial and viral meningitis, because in viral meningitis you have cell death. You have also pardon, so sorry. We also see increased immune cell function. Immune cell activity in the area, and you can end up getting increased lactate formation in those cases. Okay. C-reactive protein, another one, not very commonly ordered, but it can be ordered. C-reactive protein is an acute phase reactant, it's an indicator of inflammation, and it's actually produced by the liver in response to inflammation. The reason we test for C-reactive protein in the CSF is to rule out meningitis. Basically, if your C-reactive protein level in the CSF is not elevated, then you likely do not have bacterial meningitis. Okay. There are other tests that are better for determining bacterial meningitis, but it is possible to test C-reactive protein. Immunoglobulin levels, however, we do frequently get requests for, and the reason is we need to do immunoglobulin levels in the CSF in order to diagnose MS, or multiple sclerosis. Okay, so basically what happens in a normal healthy patient is that immunoglobulin levels, they can diffuse, especially IgG, they can diffuse across the blood-brain barrier. And we can look for the presence of those immunoglobulins if we're suspecting a particular type of infection like Lyme's disease or some kind of autoimmune diagnosis. That's possible. We can use those, but really, for the most part, Ig levels are done specifically in the diagnosis of multiple sclerosis. In case you don't know, multiple sclerosis is a disease that results in a loss of the myelin sheath. It's a reaction against the, it's a demyelinating disease. So the brain and the spinal cord are losing that myelin sheath, which results in significant CNS, significant effects to the CNS. Now they still don't really know what the ultimate cause of this process is, but at this point they still do think that it is immune mediated, hence the need to test for immunoglobulins. Okay, and what we most commonly see is that there's this area of the brain where the synthesis of IgG in particular, it becomes abnormal. Okay, so what we do is we test the CSF for the presence of IgG, and we also at the same time collect a serum. In this case, you do have to collect a serum at the same time in order to compare the IgG production in the serum, the IgG production in the CSF. And in a patient with MS, the IgG that's produced in the serum and in the bone marrow, that's going to be in both the serum and the CSF because it can diffuse across the blood-brain barrier. But in a patient who has MS, they're actually going to produce more or extra types of CSF or bands, and that would be consistent, and that's because this one area of their brain, the intrathecal sinus of the brain, seems to be pumping out all this, IgG for whatever for whatever reason, and it leads to the symptoms that we see in multiple sclerosis. So you look here, we have 5 different results for oligoclonal banding. And on the left side, we show the serum results. On the right side, we show the CSF results. So you're just separating, this is just electrophoresis banding, and you can see in a normal situation, we have no extra bands, right? It looks the same, both lanes, same number of lines, same intensity of lines, perfectly normal. In the second pattern, what we have here, we do have sharper lines. Okay, that's unusual, but likely that's a result of some kind of infection or inflammation. If you compare the two, there's not extra lines. The lines are the same still across the specimens. So while to call it normal might not be the right word, but it's still not MS. Okay. In this case here, in the third case, we have these very, very dark these large bands here where you have one or another particular type of immunoglobulin that's significantly increased over all the rest. And that's what we call a monoclonal protein, where we have one species of immunoglobulin which is drastically increased over all the rest. Again, that's not MS, and it's also not normal. It could be associated with an infection. It could be associated with several other things, but like multiple myeloma. But at this point, you know that it's not MS. In the last two, what we're seeing are where the differences come into play. So in this first one, which is your classic MS, in your serum one, you see we have what looks like a normal amount of IgG. The IgG is separated. There's no dense bands anywhere along the lane. However, when we get to the CSF, it's like 2 different patients almost. You can see these dark bands of increased Ig production, and the bands have no correlating partner in the serum. Okay, so this is classic pattern for multiple sclerosis. Then we look at the final example where you might see this in a patient. It looks like they have increased band production in the serum, right? And those are those dark lines. So some of the Ig clones are definitely being produced at a higher rate. And those have patterns or pairs at the same rate in the CSF. Well, they diffuse across, so that's not unexpected. But what the heck is this guy doing up here? It looks like a little cap or scarf on the top here. There is no concurrent pair found in the serum. So, and you can see it's not just that one. You can see there's a band here that looks darker as well. There looks like a band above that and potentially a band below that also is darker. So you definitely see extra bands, okay, present in the CSF here. So what you're looking at with oligoclonal banding is that you're looking at, it is a match. One of these things is not like the other. That's not a good thing when you're talking about immunoglobulin levels. Okay. The key thing for us in the laboratory when we're doing oligoclonal banding, and it's actually one of the things that we end up running around about, it actually has to do with processing. we get that CSF specimen in, and they don't send us the blood. We need the blood. We can't send this specimen for testing without that blood. So that actually becomes one of the issues for our processors. They end up sort of chasing the physician around. I need that blood, and it sometimes takes a while for us to get it. But that's how that specimen is interpreted. Again, more chemical analysis. Another test that we are going to look for is myelin basic protein. Again, this is usually this is usually ordered along with oligoclonal banding, and that's because it's in MS where you have a demyelinating process going on. You might find components of the myelin sheath free in the CSF. That's not normal. The myelin basic protein should be contained within the myelin sheath around the nerve cells. Okay. Normally, you wouldn't detect pretty much any in the CSF. It should be almost none. But as neurons are damaged, like in the case of MS, and in also other non-specific inflammatory conditions that happen in the central nervous system, you might find myelin basic protein in the CSF. It is not unique to MS, but you usually do see that particular test ordered along with the oligoclonal banding. That's usually what we do see. Okay. And they also use this test, myelin basic protein, as a marker toward the disease, to the disease process. So you'll see that with some of these tests. Some doctors use this, for their patients. Are they getting worse or are they getting better? If this protein is at higher levels, it can correlate. It can correlate with the progress of the disease, but it's not 100%. These things don't necessarily follow, again, according to the textbooks, how they should. Transferrin. Transferrin, I don't know if you've covered it in chemistry yet, but it's an iron transport protein. And actually, we do look for it in the CSF. It's supposed to be actively transported into the CSF. And it exists in two isoforms in the CSF, a fully sialylated variant, or beta-1, or a desialylated variant, beta-2. The beta-2 variant is unique to the CSF, so you won't find it in the plasma. So basically what we do, believe it or not, is we test for the presence of the beta-2 transferrin, that specific one, in the cavities and those areas outside of the brain. And what we're doing that to is to detect leakages. There are people, in particular those with hydrocephaly and other issues as far as increased fluid on the brain, that can develop leakages. And those leakages generally occur into the sinuses, in the head. And it's not good, obviously, to have a leak from your CSF. But how do we prove that it's actually CSF that's leaking? Well, we can test for the beta-2 transferrin, okay? And for its presence in those fluids. So this is your testing for the, you're actually testing for the specimens from the nasal cavity, from your ears, from those places. You're taking fluid out of there and you're testing to see if there's CSF in there. So this would not be you wouldn't do a transferrin level on a CSF that you know came from the CSF. Bilirubin, sometimes ordered. Generally, you're looking for evidence of a historical hemorrhage, a subarachnoid hemorrhage that may have occurred in the past, a few days to a week ago. So what you're looking for is evidence that a stroke occurred, that some kind of hemorrhage occurred. Okay. We test this using absorption spec. It's not necessary in most cases because about 97% of hemorrhages we're going to detect using CT scans. Okay. But that's not 100%. we can't detect 100% of them. So if you have a patient with neurological symptoms and you suspect a historical stroke or a historical aneurysm, well, they might benefit from testing for bilirubin. Okay, so looking for that is definitely a legitimate testing arena. And what you're looking for is, look at the time it takes for bilirubin to form. About 15 hours after the time that the hemorrhage occurred and the blood entered into the brain, you'll see the buildup of bilirubin. It doesn't occur right away. So this is why bilirubin is something you could use to differentiate between a hemorrhage and a traumatic tap potentially. If you know that there's no evidence of a hemorrhage now, but you have the presence of bilirubin, then you know that that's a historical hemorrhage. And the conventional testing that we use in our instruments isn't the same. You use the actual correct spec, the correct technology in the Maris lab. Bilirubin levels would be so low in a CSF that our conventional testing won't work. So you have to use absorption spectrometry. And that means, with the spec, you have to look at the peaks between 450 and 460 nanometers. So just to remind you, if you look, this is very small, but hemoglobin is going to show up in between 410 and 418 nanometers on your spec. Bilirubin is past that, 450 to 460 nanometers. So making sure that we have the right settings on our spec to look at this. And just one more thing, I don't have it up here, but I wanted to mention it, is ADA, which is adenosine deaminase. This is an enzyme. And this enzyme, normally it's present to salvage purines as they're converted from adenosine and deoxyadenosine nucleosides. Okay, so they're normally, this enzyme is vital. It's normally needed for lymphocyte proliferation. Okay, so it's a good marker for the presence of some kind of malignancy or some kind of immune issue. So if you have increase or decrease in this is a pretty good sign that some kind of lymphocyte proliferation, differentiation issue is going on. The electrolytes, again, we don't really test for electrolytes in the CSF too much, and that's because measuring them has shown no advantage. Knowing what your electrolyte levels are in the CSF really has shown no clinical advantage to the physician. And part of the reason is it's very difficult to know what the normal is for these levels, okay? But there are things that are different. If you look at the electrolyte levels in the plasma, you can see that the ratios are different. The cations, they're not too far off, but you can see the anions, they're significantly. We know that the proteins, the little brown area there, significantly different. So those do act for the most part as anions. Bicarb and chloride, they kind of just take up the space in between that. On the cation level, basically the biggest difference that you're looking at really is the potassium. So you're maintaining the potassium in the CSF at a very strict level. Not that it's not strictly maintained in the plasma as well. And the reason is potassium does have a depolarizing effect on neurons. Okay. And then, of course, your normal pH is 7.31. Again, we don't usually do this particular test. Its clinical value is minimal. Microbiologic exam, if a doctor orders a culture, we screen for anything that we can possibly grow in the laboratory. So what what's normal? What are the normal things that we have to look for? In the bacterial families, we have to look for Haemophilus influenzae and meningitis and strep pneumo. Okay, these are we do have vaccines against them all, so their frequency has decreased significantly, but they still are significant risk factors for meningitis. We would also be able to grow any other Enterobacteriaceae, aerobic gram-negative bacilli, listeria. These are all much less common causes of bacterial meningitis. Mycobacterium tuberculosis, you would have to order a special culture for that because this would not be found on normal cultures. For spirochetes, so Borrelia burgdorferi, which is the causative agent of Lyme, and T. pallidum, which is the causative agent of syphilis. Both of these are significant causes. We don't have vaccines against these. Syphilis left untreated can lead to neurosyphilis. Lyme's disease, we know, can track to the CNS and cause significant morbidity and mortality. Both of these we don't really grow these out. These are both tested for using serology. So this would come from that fourth tube that we look for. There are amoeba that can cause significant disease, Acanthamoeba, Naegleria, and Balamuthia. These are very rare, but you've probably heard of them, but especially the Acanthamoeba. Before, there's always some kid that jumps into a spring somewhere and it enters their eye. And unfortunately, identifying these is very difficult, and a lot of times it's diagnosed on autopsy. Fungus, however, we do have to look out for. Most common fungus that we'll get in the CSF is Cryptococcus. Cryptococcus neoformans is the most common yeast that we'll find, and it does tend to track to the CSF. Luckily, it's almost always found, well, not luckily, but and healthy people don't usually get Cryptococcus neoformans. This is something that the immunocompromised have to work for. In particular, AIDS patients, they have a history with this particular bug. But any yeast, if it gets there, can cause a problem. For the viruses, the most common virus will be the enteroviruses, but there are a ton of viruses that cause encephalitis. You've got, well, there's a whole bunch, St. Louis encephalitis. A lot of them are arthropod-borne, so mosquitoes, ticks, that kind of stuff. And then, of course, we have herpes virus also capable of making it to, we know that herpes virus likes to infect neurons, and if it can infect neurons, it can get to the central nervous system, okay? And then there's a few parasites also. This is very rare for these to be able to get to the central nervous system, but these are things that we would look for if a doctor suspected it. When we're talking about meningitis or an infection and inflammation of the meninges, the biggest thing that we want to be able to do is differentiate bacterial meningitis or septic meningitis from aseptic or viral meningitis, okay? So if anything that is aseptic would include the viruses and the parasites as well as the spirochetes. If you can't grow it, then it's on a media, then it's considered aseptic. Okay, and for the most part, in order to identify those, we use serological methods. These are just some examples of what we would look for. One of the tests that we do on CSF in the microlab is called India Ink. And in this case, this particular test is specific for Cryptococcus neoformans. So you can see the yeast cells, the budding yeast cells that are present in this field. And India ink, which is black, it's a very dark pigment. It'll turn your whole field dark. In this case, you see it's dark brown to black. But around the yeast, it is repelled, and that's because the yeast produces a very thick capsule that prevents the India ink from penetrating that capsule, and so the light is able to pass through and it looks like a halo around the cell. This India ink, which is ordered by physicians all the time, it's not the best way to test for Cryptococcus neoformans. We have serological mechanisms for doing that, which work much better. And the reason is only about a third of the strains of Cryptococcus neoformans actually produce that capsule, and so only about a third will be positive by India ink. If it is positive, you've got Cryptococcus neoformans, but if it's negative, you don't necessarily know. So it's better to use the serological tests, which have a much higher sensitivity. When you do have growth of a yeast, one of the augers that we tend to put it to in order to test for the identification is called a birdseed auger. And the birdseed auger specifically tests for the identification, or it proves the identification of Cryptococcus neoformans. If a yeast isolate turns the birdseed auger black, you see the black precipitation on this auger right there? That means it's positive for Cryptococcus neoformans. The bottom tube here, not Cryptococcus neoformans. Some of the other issues some of the other problems that we have with various yeasts. This one here, Coccidioides immitis, this is a dimorphic yeast that is capable of causing meningitis, and you can see these sphericals that are formed. This you would see in, the CSF would be sent for cytology, and they would see these on cytology. And then here's Histoplasma capsulatum, yet another yeast. You can see it's engulfed inside this white cell. See all the little tiny yeast cells in there. Okay. And here's your amoeba, your Naegleria fowleri. You can see it here. It just happened to have been found on the cell diff. Okay. Unfortunately, well, fortunately, actually, it's very rare. This is not the easiest way to find them. Okay, so this chart here you can look through. It's pretty simple. It just gives you the profiles of the most important tests. What are they going to look like for each of the different cases of meningitis? And so I have 8 different scenarios here, from normal to neurosyphilis. What is that going to look like for our main results: glucose, protein, cell count, and diff? Okay, so glucose, protein, white cell count, and diff. Here's your normal ratios. That's what we expect to see. And then each of the different situations, the doctor uses these 4 results to interpret, what am I dealing with here, and how should I start the treatment of this patient? Remember, you're going to get all these results in literally an hour from when the CSF is received in the lab, so you can start treatment that much sooner. So you definitely need to know what these profiles should look like. And these days, of course, being able to identify stroke becomes an important function of the lab. A stroke occurs when a clot either develops or travels in the brain and becomes trapped in the tiny little vessels that are there. And that will cause tissue death beyond that clot. Okay, if oxygen doesn't get through, the tissues die. Okay, this, for the most part, we talked about, I said this a little bit before, mostly these are diagnosed using some kind of imaging tool, whether it's an MRI, CT scan, whatever. Okay, it's not common that we would need to do an LP to rule out stroke. However, historic stroke, something like that, it's not uncommon. Well, I shouldn't say it's not uncommon. It has been done if they're having trouble figuring out where the neurological symptoms are coming from. Okay. There are certain tests that they're doing research on to try and get earlier and earlier mechanisms of diagnosis for stroke, for whether it's, you can call it a cerebral infarction, you can call it an ischemic stroke, same difference, okay? You're talking about tissue death in the brain, all right? And while imaging is very good, the problem is you have one CT scan or you have one MRI and you have patients lining up for it. It takes time to get access to that machine. And also, it doesn't necessarily help us to determine historic strokes and how long ago was this. So there's research about glutamate levels. Glutamate is a chemical messenger in the brain. It plays all kinds of roles with various brain functions, you know, learning, memory, that kind of stuff. But if glutamate spills into the brain tissue in large amounts, it can cause massive damage. So it could, and in the case of a stroke, the thought is glutamate is going to dump into these tissues and cause even more damage than just the lack of oxygen, okay? Now, normally, there are these dam-like structures present in the brain that disallow glutamate from being released into the tissues. Okay, so these little structures prevent glutamate from being, you know, sort of haphazardly released. But in a stroke, those little dam-like structures are burst. Okay, not just stroke, it also happen with head trauma and some other neurological diseases. But then glutamate just floods the tissues, it floods the area, okay? And that surge of glutamate will radiate out from the area where the damage was, and it'll kill the neurons, you know, as it radiates out. The increased concentrations will kill the neurons, okay? And what happens then is in that original area and spreading out from that original area, you have weakened brain function. The signals are not able to be transmitted across the neurons from that original area of damage. Okay, so at this point, the thought is, can we do glutamate levels on CSF to be able to determine if we have increased, or if we do have increased glutamate levels? That will be a good sign that tissue death, tissue damage has occurred, which has allowed this normally highly restricted molecule to be dumped out into the brain tissue. This is still research, but the general thought is that a test might be coming. And part of the reason is that there's an awful lot of movement in the area of stroke, trying to get earlier and earlier signs that a patient had a stroke. Okay.